The current recommendation from the NCCN for patients with stage 4 colon cancer who are wild type for RAF and RAS is to start out with combination chemotherapy if they are in good performance status, plus bevacizumab. Combination chemotherapy is usually a fluoropyrimidine like 5-FU or capecitabine in combination with either oxaliplatin or irinotecan. There are a number of trials that have shown that the combination of a fluoropyrimidine plus oxaliplatin is equivalent to a fluoropyrimidine plus irinotecan, so that options of chemotherapy could be used interchangeably in this setting. In my practice, I tend to use FOLFOX plus bevacizumab as a first-line choice in stage 4 colon cancer patients, especially if they are right-sided tumors or if they have mutations in the RAS pathway. The reason for choice of bevacizumab is based on the sidedness and the mutational panel. The reason for oxaliplatin rather than irinotecan is a preference related to side effect profile of the drugs in this setting. But that being said, using bevacizumab and FOLFIRI in the frontline setting is a very acceptable standard of care as well. So for younger patients who are very well fit, there is an option of using a triplet regimen, which includes 5-FU, oxaliplatin, and irinotecan upfront, in combination with bevacizumab. An approach like that would carry a higher chance of response, but it does carry a higher chance also of side effects. And therefore, you have to be very judicious in who you select for the triple regimen versus the double regimen. On the other end of the spectrum, for older patients, like patients in their 80s and above, or patients who have borderline performance status, there is also option of using a single chemotherapy regimen with bevacizumab, and the regimen that most commonly used is capecitabine plus bevacizumab in that setting. If this patient had left-sided colon cancer, the options for therapy in the frontline setting would be more complex. Patients with left-sided colon cancer and RAS wild type could either start with a combination chemotherapy plus bevacizumab or combination chemotherapy plus an EGFR inhibitor. Both options would be viable options in that population. Physician's choice between bevacizumab versus EGFR inhibitor depends on differences in side effects and patient preference, but efficacy-wise, the two regimens appear to be acceptable options in left-sided colon cancer. My personal preference in my practice is to use bevacizumab upfront because I feel that the side effects of the bevacizumab are less intrusive as compared to the side effects of EGFR inhibitors. And specifically, I'm talking about issues related to skin toxicities, which can be very intrusive in patients' quality of life.